sunshine. And I have to say, it does feel a little bit as if spring is coming, not just by the sunshine and the snowdrops and I've got daffodils out in the garden, but also because, and I know Steve will touch on it in his chief exec's report, things do look a little sunnier in terms of COVID within the trust. And that's hugely encouraging and brilliant for our communities and for our people. So welcome. I'm going to move straight into the agenda, because although we've rejiggled the agenda a little to give us a little more discussion time, I want to make sure we use it really effectively. So my usual premise about brevity, focus, remains exactly the same. Okay. Do I have any apologies for absent other than Kate Thornton, who I know is not with us this month? We haven't got George. Richard, are you aware of any?
Sheila, Angus is having trouble getting in, so I'll just resend the link to him.
Thank you, Louisa. I will gather then we don't have any. Okay. Declarations of interest for the items on the agenda. Do I have any in addition to the normally declared ones? Take that as no, thank you. Questions from the public. I have some questions which Liz has sent in as lead governor in advance. I will read them briefly. There are a couple I will ask to be picked up in the reports, and one, Steve, I'd like you to touch on in your chief exec report.
Sure.
So the first question is around assurance that the position of the supernumerary person intended for the labour suite is being resolved. Sue, I know that's in your report, but will you make sure that you cover that point carefully?
Yes.
And a further maternity question, and clearly this is a focus for the board. The mandatory training overview shows a worrying percentage of fetal monitor training. Although the present situation with COVID may have caused this, can we be assured it will be addressed?
Karen will cover that off in her paper.
Okay, thank you. As long as you both cover it.
Yes.
And Liz, I know you'll be out there. If we don't cover it to your satisfaction, please come back to me and we'll make sure that it is sorted outside the meeting. And there is a further explanation, Steve, which I'd like to put in your court, and it's around ED development, because I think there is a degree of confusion, because in the finance paper that went to COG a little while ago, it implied expenditure had been halted on this, and yet the report talks about money spent today. So can we just clarify what we're not spending and what we are spending? And Steve, I've said chief exec's report, but it may fit better with Craig's finance report. I don't mind which way, as long as one of you cover that off, because I've had some questions raised to me around the ED, because I think the situation has changed as we've moved along. Okay, so between you, please. Richard, have you had any further questions?
No, there have been no further questions, either directly emailed in or via the website.
Okay, thank you. Thank you very much, Liz, for your questions. We will make sure those are picked up, and as I say, if they're not answered to your satisfaction, please come back to me. On the agenda, Richard, I don't believe there's anything we need to rejig for external people coming in or any other reason. Thank you. Minutes of the previous meeting then. Please, could we move to the minutes of the previous meeting? Bear with me for a second while my machine catches up with itself. I'll take these page by page. Please, can you indicate if you want me to stop? Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, And I doubt if there's anything on 16. Okay, may I sound those as a true record, please? Thank you. I'll take that as a said. Thank you very much indeed. Could we then move to the matters arising? And if I look at the first page there, which are all green, most of them are for next month. And we have one on staff, which I think, Jeremy, you will cover off in today's report.
Yes, indeed, and there's some additional narrative that describes what we've been working on in the last sort of week to 10 days that isn't in my report that I will elaborate on when I present.
Thank you very much, and we're very much enjoying your birdsong. If we can move to the second page then, please. Those actions are all complete. I don't intend to go through them one by one unless you have a question on them. And David, I see your hands up.
Yeah, sorry, I think there's one action that's been omitted from the action follow-up arising in last month's minutes, which was around the possibility of introducing virtual ward visits. I don't see that that's been picked up as on the action tracker.
Richard?
I'll pick that up, David. I think it's probably because there's an element around that which is there's a closed board action, but I think it should be reflected in the open board actions as well. You're absolutely right.
Yeah, there's no reason why that wouldn't be in the open board. Thank you. Yeah. Helen?
Could I just go back to the open ones, please? I'm just concerned that 1915 talking about community effectiveness metrics to have that by next month may be ambitious given all of the work we're doing around the kind of the capacity demand, the input, the scheduling, and I think the output metrics may just take us a little bit longer as the team are really focused on all of the rest of it. So if I could just ask for a little bit of leeway on doing that, just because I'm really concerned about the people who will need to develop that are very involved in doing all of the other data pieces at the moment.
Helen, can I suggest you update us next month?
Absolutely.
So that we we definitely have an update and we'll have the metrics as soon as possible.
Yeah. Okay. Happy with that.
Thank you. Jeremy.
Thank you, David. Actually, just helped me spot another one which has my name next to it, which relates to freedom to speak up data and an action in the minutes assigned to me on that, which isn't in the tracker. Just wanted to assure the board that next month you will receive a combined report from me and the Freedom to Speak Up Guardians that will provide that elaboration. So that will be forthcoming next month.
Okay, thank you for that, Jeremy. Okay, I don't see any other hands up, in which case, can we move on, please? And can we move on, please, to the patient staff story? And Sue, I think you're leading on this today.
Yes, Sheila, I am. We've got a couple of some feedback from both the clinical helpline and the Keeping in Touch service, which I thought would be good to bring to this meeting, especially after the last few months we've had. So some nice messages about the Keeping in Touch video calls to complement the helpline. There are 3, so I'll read them out. To all the Zoom team, good afternoon. I would just like to say a huge thank you to everyone in your team. You definitely work miracles. Zooming with our mother was a lifeline for her and us. We absolutely appreciate everything that you did. Communication was essential for Mum to aid her recovery, especially on F10 with COVID. Help with her personal phone was a godsend to us all, and you selflessly donned PPE to set up the technology. Your safety at jeopardy too. We have sent a large bag of goodies to the ward, and please share with your team too. Thank you so much. We're eternally grateful. Another one. My father passed away yesterday. Although we are heartbroken, I wanted to thank you all for everything you did to enable my brothers and I to see him so regularly over the past month. Without your service, the situation would have been absolutely horrendous. We will take great comfort that we shared some time with him before he died. Thank you all again, and do keep up the amazing work. And then the final one for keeping in touch. Hi, this is a daughter of a patient who sadly passed away last Monday. I would just like to pass my huge thanks to you all for providing this wonderful service for those who cannot visit their loved ones whilst in hospital. Because of you all, I had a few nice moments with my dad before he passed. And then I've got one from the clinical helpline as well. As you know, the services complement each other. I wanted to thank the advisors, whom were so friendly, caring and helpful on the telephone when my father was taken into hospital having had a fall from his care home. He has dementia and has been very confused about why he cannot see me, his daughter, or his wife shielding in a separate building in a care home throughout the COVID-19 pandemic. He was particularly confused and upset that I could not be with him when he was in pain and going to hospital, as I have always been there with him in the past. As I live in Hertfordshire, I feel miles away from my parents at the moment. The helpline nurses I spoke to were all very kind and helpful, providing me with updates about his tests, results, and whether he would be admitted or released back to the care home. I did not have to wait long to get through on the telephone. They also told me about the Keeping in Touch Zoom video facility if he was admitted, and even noted a brief message from the nurses to give to my father. I would particularly like to thank Una, who was working from home in the role. Many thanks. I have today provided a good positive feedback on the CQC website, though I did not mention any names. Thank you.
Thank you, Sue. And I think it emphasises how vital that service was to so many families. It really was an absolute boon. And I think the other thing that struck me very strongly was the allusion to somebody working from home. So it enabled people to still do their bit, even if they weren't able to do their normal role within the trust. And for our caring staff, that must have been a huge frustration. And I know, talking to members of staff who were working from home during that period, you know, they felt as if, it's a dreadful thing to say, but in some ways as if they were letting their colleagues down by not being there, but they knew they had to be doing what they were doing. But to be able to contribute so much, I think was brilliant for the families, but also extremely rewarding for the staff. Steve, and then Alan.
Thank you, Sheila. Thank you, Sue. Yesterday, I went back to the floor with the patient experience team and first joined the morning clinical helpline huddle, then went onto the wards with the Keeping in Touch team, and then had the privilege to listen in a training capacity to some of the calls taken by one of the shielding members of staff that has joined the clinical helpline, and it was a fantastic morning. People's enthusiasm was very, very apparent. That the look on some elderly patients' faces as they were connected with their families and their loved ones, you just can't underestimate how powerful that was, and that really, you know, made a massive difference to the patients and their families. It was also really, really striking when I listened into the Keeping in Touch service. Both the Keeping in Touch and the clinical helpline really take advantage of our IT system, whether that be the enhanced Wi-Fi, the recycled iPads, the remote access to the clinical records, to the use of the net call system that our IT system uses to stagger and introduce and relay to people's personal mobile phones on our cost the calls. It was a really great service that has been set up quite rapidly at the start of the pandemic and is really valued. I spoke to several ward managers yesterday and they really valued the service. I think the final thing to say, it was also really good to see both safeguarding issues and GDPR issues being appropriately worked through. And also, when the staff huddle took place, there was a real focus on making sure that the staff who were working, what were they going to do when they finished after the day, and that was really quite important. And when I spoke with Cassia after and just explored that, some of that was about making sure that people turn off when they're at home and finish the day and think about how they actively switch off. And I just thought it's a great service. I think the question for us as a board will be, and I know we will be contemplating some of this as we think about the financial budgeting situation for next year, is how we continue these, I think, really innovative services. So I just wanted to say that, because I had direct experience of it yesterday, and it was fantastic. And I pay tribute to Cassia, Charlie, Anna, and the team. It's a really great team and great initiative, and staff, those that have been supporting it and those that have benefited from it, really appreciate it.
Thank you very much indeed, Steve. And I suspect Alan is going to respond equally positively to the service. Alan.
Yeah, thank you, Sue and Steve, for your introduction of those topics. I had a question really for Sue and Helen, which is there an angle on this service which relates to community services? We've got a cohort of patients who are out there in the community, probably more in the future. And is there a sort of angle on keeping in touch whereby there's absolute clarity of how those patients and their families can easily keep in touch? If perhaps no one's called on them for a while or they've got some concerns. Is there as much clarity on that as there is for our inpatients?
I don't know, Sue, Helen, which of you would like? Sue, you've got your hand up.
Well, Helen might want to come in too. My view would be, actually, Alan, this is something we should absolutely look at in the future. I think that it's become very apparent that our community teams are now delivering more and more acute care in patients' homes, and as you quite rightly say, they may well also be socially distanced or distanced by miles from their families, and it's absolutely something we should look at setting up. As you know, we're hoping to substantiate both services going forward, and then I think that's a development opportunity for the services to look at and absolutely work with our community colleagues.
Well, Helen?
So I agree with Sue. However, just to assure people, there are variations on a theme that happen not necessarily from our community teams, but often from third sector organisations in the community that both seek to support individuals who during the pandemic are really trapped, there's no other word for it, in their own homes, but also to support the families of those individuals. So there is work that happens at an alliance level, which is along these lines, but absolutely doesn't do what the Keeping in Touch service itself does. But for example, if in their own home people have got access to an iPad or whatever, then some of the third sector organisations have been running similar services for us.
Thank you.
I think what's very clear, whether it's this service or more clinical services, we've discovered so many different ways of working during this period, and it's one of the quite simple but basic things we really need to keep and grow as we move forward, because this has really been innovative and has taken us much further than any of our ideas have in the last 10 years. We've had lots of ideas, but we've made it happen. And if you can make this happen that quickly, we can make a lot of other things happen quite quickly. Right, I'm going to move to the Chief Executive report. Steve, we've had the opportunity to read your report, but I'm sure there are a couple of highlights you want to pull out.
Thank you, Sheila. So we have now, it looks like a roadmap out of lockdown, and that's very, very welcome, and strong evidence that the vaccines are effective. And so that's really, really encouraging. The pressure on our acute services has significantly reduced, and I'm sure Helen will touch on that. The community teams, though, still face quite significant demands and pressures, and we thank them for all the work that they are doing on supporting our patients out in the community. It is clear that we are seeing real increases, significant increases in our waiting times and some of our 2-week waits for cancer, and we'll say what we are thinking around that. We are working and having conversations with staff in terms of how we reset and restore activity, and hopefully try and improve access for our community as we go forward. So there's quite a lot of thinking that's going on around that. I think Craig will pick up the issues around the ED department and funding, but in essence, the larger scheme that we were planning, we've stood down, but we've made small changes, or significant changes though, to the footprint of our emergency department, and those have come on stream in recent weeks. And the estates team has done a fantastic job, and I pay a big tribute to the estates team for all they've been doing on that. If I can just pull out the Love Yourself week that the comms team, supported by our psychology team and some of our Pilates experts and the trust's head chef, we saw some great sessions setting out what people can do to look after themselves, and I think that was a really fantastic week, and it just underscores how we are trying to prioritise our support for staff. We also continue to reflect on what we're doing around thinking about how we support our staff to speak up, and we heard from Megan Wrights, and I'm sure and I hope we'll reflect on that at length, because that's something that we are committed to improving as we go forward. There's quite a lot of focus on that. Also, there's some real praise for staff that I pull out in the report, and it's great to see staff continuing to passionately improve services and care about the service that they give to local people. And so great to see that and to shine a light on that. Finally, and there is a longer briefing in the pack. The government has announced some quite significant legislative changes, and that will have ramifications for us, and some of the thoughts of NHS providers are set out in the attached briefing. Happy to pick up some questions.
Thank you very much indeed, Steve. And in terms of the white paper and the thoughts from NHS providers, I know that the board will have read it. We're also setting up a session for the Council of Governors to talk about integration and the wider issues around the potential of integration, the white paper, that whole system working approach, which is clearly going to be the way things are in the future. Louisa.
Steve, thanks for your report. I just wanted to touch on the COVID virtual world. Obviously, that's another sort of digital initiative to support both acute colleagues and those in the community. And I just wondered, once we've evaluated and sort of got the learning from it, are there any plans to actually develop that and replicate that in other specialisms?
Shall I take that, Steve?
Yeah, go on, Helen.
So absolutely, Louisa, it is it's definitely got potential, and another one. Sheila alluded to things we've been trying to do for many, many years and haven't succeeded. So I don't want to give people the wrong impression. The virtual ward is more like a virtual bay at the moment. We are talking in less, single digit figures, but I think that's important as we get the service up and running. But there are a myriad of services. Heart failure patients could be monitored really well in their home environments with digital technology. A number of frailty patients. So yes, absolutely, Louisa, that's got to be the way we work more in the future.
Does that answer your question all right, Louisa? Okay, Rosemary.
Thanks, Sheila, and thank you, Steve, for your report. You talked really eloquently about the cultural journey that the Trust is on. And from my understanding, I thought it might be interesting to hear your thoughts on where we are on that cultural journey. And as part of that programme, what will be, in your opinion, the next key issues that we perhaps need to focus on? And also, are you considering perhaps how the board needs to do things differently as a result of the feedback that you've received through the process?
Sure, Rosie. So, we have had a significant engagement with staff, what matters to you, and we fed that back to both the board and the organisation. And on the back of that, and then combined with the national publications around the national people plan, we've produced our own people plan, and we'll consider that later in today's agenda, and I think get a bit more granularity on some of the. And if you go through Jeremy's report, you'll see there are certain things to the end of the year, and then certain things beyond that Jeremy talks about. We will shortly be receiving the national NHS staff survey. So over the next month or two, we will be formally bringing that national staff survey back to the board, and that will give us further opportunity to both not only link it to what emerged from what matters to you, but also to have some comparative understanding of how we fare. What I think the priority, though, will be, I think many of the things that we are doing are probably the right things to do. I think the question will be is whether we're going further fast enough on some of our cultural journey, and I suspect we need to think. We'll continue to need to think about how we provide the psychological safety to staff to encourage them to speak up, how we become more of a learning organisation. We have learning reports on the board's agenda today, but I also wonder whether we should be doing a lot more about having the discussions about some of our patient stories or some of our incidents, not just in board reports, but in some of our discussions with staff, staff briefings, and staff communications. So I think we will need to do a bit more on that. I think the other thing that I would draw attention to, Rosie, is thinking about how we support our managers, and they have a really difficult job because the NHS will ask us to do things, and we'll ask the managers to do things, and they'll have staff who they are supporting. You'll be asking them to do things, and balancing that is a really difficult juggling act, and we need to make sure that they are the best that they could possibly be. And I think making sure that we support both our staff and pay attention to how tired they are, but also make sure that we've got the skills in our leadership to help us continue on our cultural journey, I think has got to be the key. We're also doing our board development work, and that's I think key for us to grow as a board. But in terms of the organisation, those are some of the things that I think we need to focus on.
That's really helpful. Thanks, Steve.
Thanks, Steve. Richard, and then Alan.
Thank you, Steve. Thinking about highlights of your report, I just wanted to pick up on the appointment of Natalie Bailey as Head of Mental Health, which looks to me like a fantastic initiative, bringing a focus onto mental health issues in the acute trust and in the community and linking to partner organisations. And as Natalie says, seems to be quite a unique thing. It may not be the time to do it, but I'd be very interested to hear more about what that role involves and what she'll be doing. And I wonder if we will have some opportunity at some point to know more about what Natalie is going to be up to.
Steve, can I suggest we perhaps have a very brief presentation on that at some point? I mean, do say something now briefly, but I think probably we need to understand a bit more how that fits in with the service.
Yeah, well, I think let's maybe either get Natalie to come and speak to the board, or we could have a report from Natalie that might be as part of the quality papers that we consider.
Richard, would that be helpful?
That would be perfect. Thank you.
Yeah. What I don't want to do is have a few superficial words when actually this is quite an innovative step and deserves a little bit of focus and attention. Alan, you wanted to come in.
Yeah. The last item on your paper, Steve, is about the white paper, and we're all excited, I know, about integration with social care. Would you like to reflect in public for a moment on what that'll mean for us? I know there's talk about having a shared director between social care and health in our area, and I note that we never really talk about social care in our board at all. And I just think, do you think over the next year or so we can really make moves towards that so that we feel even more like an alliance across social care, sort of almost get ahead of the game on the white paper?
I'll ask Steve to comment, but I think, Helen, you may want to make some comment. And I think also, too, it's worth commenting that I've asked Rosie to play a particular role in getting a little bit more engaged with the Alliance and with the independent chair of the Alliance, so that we begin to create more links across, which is health, social care, third sector, that broad gamut which forms the Alliance. Steve?
So I suppose, there is much that brings us ever more closely together that is proposed around the white paper, but there are still, I think, fundamentally will be two distinct, in a sense, systems around social care and NHS care. What I think our aspiration locally is to do is to blur those boundaries within in a sense, the legislative and statutory framework. And while we are talking about joint post, a joint post and joint posts, that will also manifest itself in terms of greater integration of teams and greater co-location of teams and greater liaison with teams. I think there is a question for us whether we should, as a board, understand more about the social care, both framework and market, and what that means for us in terms of our services and the impact upon our community. So I think there is something that we will need to do around that, and hopefully this combined new post will give us that, I think, and I think that gives us a great opportunity to really accelerate on some of the opportunities that are there in the white paper. So I think personally, this is a great opportunity which reinforces much of what we're, I think, already doing. Helen, do you want to add?
Well, Helen, I was going to suggest we move into the operational report. I have no more hands up. And can you pick this up at the beginning of your operational report? So we'll move seamlessly, if we may, from one to the other.
Okay, that's absolutely fine. I'm obviously going to assume that the report has been read, but there are a couple of points I wanted to pick up. Most of these are things, because the pace operationally is moving very, very rapidly. They're things that perhaps in the paper were alluded to and have now crystallised a little bit further, or changes that have been made. So if I start on page 67 in terms of where we are with COVID, regionally the critical care position for is still above the baseline capacity that we had pre-COVID, and therefore we have to be quite careful. There is still a potential that we may need to give mutual aid. However, our own critical care unit earlier this week consolidated back into one unit, which does make it easier for the staff. It's easier for them to work as one team as split. In terms of the picture with COVID numbers, they are still declining, but the rate of decline has slowed. But the east of England figures are better than a lot of other regions. There is a suggestion, not backed up, they admit, with any clear scientific evidence, but there's a suggestion that there may be a potential for another surge again in the autumn. And whilst that is considered to be an unlikely scenario, we are definitely being encouraged to have that within our thoughts as we plan going forward. If I move to page 68 of Convene, and just a little bit more detail around the reset, which is the phrase that is being used around how we start to restore services moving forward. So I joined a regional conversation yesterday, so I thought it might be helpful just to give you some of the headlines from that conversation. As it stands at the moment, we don't have a clear national steer on what resetting and recovering waiting times might look like, other than a real exhortation that we need to treat patients in clinical priority order and high clinical priority patients first. We're currently being asked, as it stands at the moment, to develop our own local plans for what we can deliver in Q1. It's thought that by Q2 there may be some more prescriptive requirement, but at the moment we're being asked to develop our own local plan. Now, there is nervousness around that, both within the organisation and within the region, because this is exactly the same pattern that we saw as we came out to the end of the first surge, i.e. tell us what you can do, and then there was then a national instruction to say, no, that's not quite what we want you to do, and we want you to do something, we want you to go further, faster. I think the risk of that is reduced because there is both a local, regional and national recognition that as we're coming out of the second wave, our staff are exhausted. A recognition that different organisations have fared differently and different staff groups have fared differently. A really nice expression that I heard was, we may have all been in the same storm, but we've all been in different boats. And there's a real recognition that people have experienced this wave differently, and we need to bear that in mind. The next piece of information was that we should expect to be maintaining the current level of infection prevention and control guidance at least to the end of 2021. And as I think you all know, that will impact on our capacity and our ability to deliver. There's some concern at the region that at the moment there is no national focus on community services, and I know we are lobbying quite hard around that issue to make sure that those groups are not forgotten. I'm sure Craig will talk in great detail, but at the moment there is no real clear steer on the financial envelope that we're going to be working in, and clearly that makes it quite difficult to make your plans for recovery and delivering additional activity. the regional steer at the moment is for people to only be doing the first 2 priority cohorts of patients. However, I am expecting some written communication to come from the regional team today around what they're looking for, which should mirror what I've just told you. We, as West Suffolk, will get a special dispensation to go further and faster during the next couple of months in recognition of the challenges we are going to face when we move into the rack plank scenario. So that's what I wanted to cover in regard to that.
Thank you. Can I stop you briefly there, because I've got some hands up, and in case
you certainly can.
You've said so far, I'll pick those up now if I may.
Okay.
David.
Thanks, Helen. As you've outlined, the reset process, there are a lot of uncertainties around that. But as we come out of lockdown, I expect patients will be expecting to get back to being treated. I'm just wondering how we're going to communicate both individually and collectively with our patients out in the community in terms of what their expectations can be.
So we're currently developing our plans because it is more challenging for us at West Suffolk with the rack plank programme that is going to hit just at the point that we're expecting to get the instruction to step up the pace. We are developing those plans and they will go to the next scrutiny committee. So I think that will give us our local picture a little clearer, because we're looking at what mitigations there are. We're also waiting for some national steer on what might be expected, but I think then there will be communication regionally, communication from the CCG and communication from us. The last time when we came out of this, we did a blanket communication to all patients. That didn't go down terribly well with our clinical teams, who wanted more control of the communication with their patients. So we'll be mindful of that this time. There will be individual patient communication, but it may be different in different services, and we'll work through with clinical teams to see what that looks like over the next couple of weeks.
Thank you, Helen. Angus.
Thank you, Sheila. First thing to say, Helen, is I think this report is really clear, and thank you very much for that. And what I'm about to say might reveal a competitive side of me. One of the bits I really liked was the appendix, to see how we compared. And I was reflecting on where we want to be as an organisation, and I think we should be ambitious. And I was wondering whether some of this comparative data that we have might be a source for us to almost aspire to stretch ourselves to be the best or the top quartile relative to peers. I appreciate that you have to be ever so careful with benchmarking, but nevertheless, I just sort of plant that seed, because I accept the fact that we were all in different boats, but I think our patients will view us as a flotilla and they won't understand the subtleties. So I'll leave you with that thought as you move forward. But I also think culturally it'll be good for us to have ambition and stretch, because ultimately we want to be exceptional again.
So I absolutely agree with you, Angus. And I think when we get to the IQPR, and I know I'm jumping slightly, but some of the historic measures I don't think are going to be helpful for a little while moving forward, because, to be honest, monitoring 52-week waits, when we're looking at them maybe going down from 3,000 to 2,900 is still it's too big a thing to look at. So one of the things I've suggested is that when we've got some clarity around the national expectations and the plans, we agree collectively some different metrics, and some of those may absolutely be those kind of activity-driven metrics, etc. I think we need to put some more nuanced metrics into the IQPR that will help us to do as you're suggesting.
And just to clarify, Helen, so there's a point around, right, what is it we hope to get achieved? And I think we should also think, right, at a stretch, what could we achieve?
Yeah.
Just think like that.
Yeah, yeah.
That's a useful prompt, Angus. Thank you. Rosemary.
Thanks, Sheila, and thanks, Helen, for your report. And I know that your team have had to also work incredibly hard through the pandemic, so thank them for that, for their hard work too. Just a quick point on endoscopy, and it seems that there's quite a lot of actions going into that area. Can you give an indication of when you think we'll really start making an impact into that backlog in endoscopy, and then on and how confident you are about the measures that you've taken? And then on a slightly different issue, when you talk about the reset and recovery and the local planning, does that include for the community as well as for the acute hospital in terms of recovery planning? Thank you.
Thanks, Rosie. Let me pick the endoscopy first. So I've included, I'm sure you'll have noticed, an awful lot more detail around that in the paper, just because it's been a specific area of focus. We were on track to be, so endoscopy gets measured in lots of different ways. The first critical thing is to be able to deliver the 2-week standard for rapid access patients, and then there is a more general 6-week standard for routine referrals, and then there is keeping on top of surveillance patients. So there are different streams of activity, and each of them has got different trajectories, but the first one we really need to get back on top of is the 2-week wait standard, rapidly followed by the 6-week. We were slow to come out of the first wave. We had, I think sometimes these things uncover an awful lot of operational challenges that maybe you didn't realise were there until you end up in a crisis situation. We'd got lots of people, I think, working extremely hard, covering over cracks. And what we needed to do when we came out of the first wave is a complete overhaul. And I'd like really to pay tribute to our new cancer lead, Antonia Wells, and that's a post that has got additional clinical time allocated to it with some funding from the Cancer Network. And she has done an amazing job of both supporting everything from an administrative review of booking to pushing forward and getting funding and agreeing some new clinical procedures which will divert activity and reduce the burden. So Antonia Wells is doing a fantastic job, and in fact put most of the content together for that section of the paper. We were on track to deliver the 2-week wait standard by the end of January, but unfortunately we then got hit by the next wave. So we had to close an endoscopy room again. We protected more activity this time than we were able to do. People may recall in the first phase, and the reason this problem is so bad was that national guidance was to do no endoscopy other than life-saving emergency work. So we created an enormous problem nationally, and then locally we struggled to come out of it. So if I have to give you, no, I'm not going to give you, because the demand has gone up as well as the recovery trajectory gone offline. But we're probably another 2 to 3 months before we can reliably say we'll be delivering the 2-week wait standard. However, during that period of time, I expect to be able to see, and we'll put a trajectory together over the next couple of weeks, which we'll share at the next board. I expect to be able to see step changes and improvements quite quickly along the way.
Thank you, Helen.
Thank you, Helen. Louisa and then Steve.
Helen, I also, like Angus, really like the report, nice and clear, and I like the idea of a bit of competition. I know throughout this sort of challenging period, we've had the facility of the BMI, and I know that you've previously done a lot of work insourcing, outsourcing, so that we can really hit those lists. Can we be assured that that will continue as we move forward to secure that treatment for our patients, and again, that we'll lobby sort of regionally and nationally around additional funding for that?
So we have access to, so the region, sorry, not the region, the ICS implemented something called Surge in February, and we once again gained access to 100% of the BMI capacity. That sounds great. That's not an awful lot of capacity in the scheme of things. It's their funded capacity, and they tell me they're funded to run 10 sessions a week. So it really isn't an awful lot of capacity. That national funding finishes at the end of next week. For planning purposes, we had agreed with the BMI we would work in that way with them anyway for another week, just because the national notification is so late, we needed to get on and do the work. At the end of March, all of these national arrangements stop, and we have been clearly told there will be no national funding and there is no national contract. So we have to go back to previous arrangements. The CCG do some directly contracted work with the BMI, and so far they have been the indication is that the level of funding will be the previous baseline level of funding. But from the regional conversation yesterday, there's an expectation that's just a holding position until we understand what the financial envelope from the Treasury looks like. So that's the plan at the moment. The only other reassurance or I can give you, Louisa, is that I'm having conversations with the managing director of the local BMI to see what else we can do under local contracts, and to see if during the rack plank programme, if we've got teams of staff who can't work, could we go and operate more of their physical capacity. So we're having those conversations at the moment. They are quite slow to progress.
Thanks, Helen.
Thank you. I've got Steve and I've got Nick. I'll take you both briefly and then we must move on.
Thank you, Sheila. I just wanted to pick up Angus's point earlier, because the comparative information is really, I think, great to see. One of the points that I've raised with the regional team, and I'm going to do some work with Adam Cayley, the Regional Director of Performance, is about getting a better comparative dashboard out across the system so people can benchmark and understand where good practice is, and also understand how we are faring. So I think it's really, really important to get that. But I just wanted to say we will need to bear in mind some of the constraints that we, and the starting points that we are. So Helen's just mentioned the rack plank situation and so forth. So, there will be a lot about being innovative and doing things differently, and maybe using capacity such as the BMI that Helen's just talked about and so forth. But there will be certain, shall we say, limits around and constraints that we'll have to work with and so forth. So we just need to bear that in mind as we're looking through that comparative information. What I think is likely to emerge, and this picks up, the wider point around the changes to the ICS, is there will be questions about how we are doing in terms of waiting lists across the ICS, and how we are collaborating to address and deliver the best possible service for our patients and so forth. So that links back to Angus's other point. but there's something about we need to look at that from an organisational perspective, but also a system perspective, and think about is there anything that we can do about managing waiting lists differently, and do our patients want to travel? And sometimes they don't. It's a very frail elderly population, and we've been engaging with clinicians on these very issues to think about how we collaborate, how we stand stuff up, how do we balance tired staff and so forth. So that comparative information drives a range of conversations, but not necessarily an internal, just an internal exclusive focus, but also how we work differently with other providers and across the system.
Thanks, Steve. Nick?
Thanks, Sheila. I just wanted to add to what Helen said in response to Louisa's question. So regionally, there is a great clamour for continued use of the independent sector. Relatively speaking, we make relatively little use of our local hospital because it is little and local and can't do some of the bigger surgery that many larger private hospitals in the region can do. And so Sue and I were in a meeting with our respective regional colleagues earlier this week, where all round the region people were saying we're going to be in all kinds of trouble if we lose access to that independent sector capacity. So it is not just us who has the issue, and we probably have a smaller issue than most.
And I mean, that does point again to work more collaboratively across the system, doesn't it? Right, at that point, I'm going to move on because we've spent a long time on that section of the report. Helen, did you want to finish off yours, and we'll move into the IQPR then?
So I haven't got much else to say, just to draw people's attention to the paragraph on page 69. There is now an expectation that the clinical review of emergency department standards is going to be rolled out across the country. That's the thing we've been piloting for much longer than any pilot should have run for. The consultation around that has closed. And we're awaiting information about exactly which bundle of standards there will be, but I've given a bit of an indication of where we're expecting them to look at, and as I get more information about that, I will share that with members of the board. And finally, just the community update. There's been a few references to there is talk of a joint director post. There's more than talk of. We are in the recruitment phase of appointing that post. I've been in discussion with Sheila around a couple of NEDs to join the stakeholder panel, and if it's not arrived yet, it will be winging its way into our lead governor's inbox for an invitation to her, or to nominate a governor to join the stakeholder panel. So good progress is being made around that, and that will be somebody with health and social care in their portfolio who will sit around this board table and sit around the ED table, and I think will be a great addition. So I think that's all I had to say, Sheila.
That's great news. Thank you, Helen. I mean, it's turning aspirations into reality, and I think having social care, somebody with a half a social care hat on the board, will be a real addition to it, and embed us more in our ways of working in the future. Okay, at that point, I'm going to move across into the IQPR, where you talk about community metrics in the introduction. So that's a nice seamless move. Do you or Sue want to start on the IQPR?
I'm happy to start because usually the performance things come first. I don't have too many points to make. I was going to just pull out where we've got on page 75 RTT compliance. I think we need to develop, as I've just said, some more helpful metrics there. I think if we monitor RTT compliance, we're just going to be monitoring failure for at least the next couple of years, and so we need to find something positive so that we can engage in that competitive approach that Angus has talked about.
Helen, can I just ask, that's something that really needs doing region wide, as well as for us as individuals. I know we've got some individual wrinkles like rat planks, but you know, the whole region must be experiencing the same issue.
So I think that is correct, and what I'm expecting to come down, I alluded at the beginning to currently a lack of national direction, but the only key message that's coming out is around clinical prioritisation. So I think we can see targets and expectations to the delivery of, when we talk about P2 cohorts of patients, all of the cancer activity fits in there, plus another cohort of patients. So P2 patients should be operated on within a month of a decision to treat. So I think we can expect to see that we monitor our compliance with treating P2 patients in a month, P3 patients in 3 months, etc. So I think there will be some regional and national direction, but at the moment I'm slightly second guessing what it might look like. Okay, thanks, Helen. Right, do continue. To be honest, I'm just looking through. Yes, there was one point I wanted to make again, and around the 2-week wait for urgent GPs, which is the standard that is being very impacted by the endoscopy position. But I think quite soon we will see that one superseded by the 28-day diagnostic standard. So rather than 2 weeks to see somebody who can start your diagnostic pathway, it will be a standard looking at concluding your diagnostic pathway in 28 days. I wanted
Richard at that point on that one. Yeah, I suspect that's probably where you are, Richard.
Sorry, it wasn't about that. I was going to come back at something else. So
okay, Helen, just finish what you're saying. Then I apologise.
That's okay. In terms of the 62-day standard for treatment, that is absolutely being impacted by the diagnostic wait. I just wanted to assure people that once we do have a diagnosis, we are able to treat our patients very rapidly. Even with our reduced activity, there are no delays for people to get treatment once they've had a diagnostic. The exception to that is just the little note in the 104-day waits, where unfortunately, due to the really, really significant critical care demands in some of the tertiary centres, there are delays for some of our patients who need treatment at the tertiary centres, and we still hold those patients on our waiting list because they are our patients. So you'll see a slight impact from that as well. And that's me finished, Sheila.
Thank you, Helen. Richard.
Thank you, Sheila. Thank you, Helen. Can I come to the community report, the community non-consultant-led 18-week waits at page 85 on Convene, and the sort of alarming waits for speech and language therapy, particularly in wheelchair services. Now, I know speech and language therapy has been severely impacted by COVID. It's hard to see why wheelchair services have been so impacted. And I note that both services were struggling before COVID, and the narrative talks about papers and support from the CCG in understanding demand and increasing resources. And that's the same narrative for last month. Can we hear a bit more about what that involves and where we're going to see some improvement and how we're going to see some improvement?
So I'm expecting to see something come out in the financial budget for this year that reflects we need some additional resource. Wheelchair services are, the provision of the wheelchairs are quite expensive items, and therefore the demand outstrips the numbers that we're funded to provide. So that paper really is around trying to address that. They have to some extent been impacted by COVID because they do require people to come and be fitted and measured and make sure they've got the right device. And of course, a lot of our wheelchair patients have also been shielding and have not therefore been able to come and access the services. But in both speech and language and wheelchair, we are expecting to see additional resource in the budget allocation so that we can recruit accordingly.
Thank you. That's very helpful. It's just that a 26-week wait for a wheelchair, it's not a very sexy. It's easy to lose the importance of that, but actually that's a big wait for some mobility. Yeah. Thank you.
You're right, Richard, and I'm not sure whether you recall pre-COVID, but we did an awful lot of work to improve that position. And we spent an awful lot of money delivering additional activity, and some of that has gone backwards, I think, because we've not been able to physically access those patients.
Thank you for raising that, Richard, because it is an important service. I mean, it really does affect people's ability to live as normal a life as they can. Okay, thank you for that. Sue, can I hand over to you then, please?
Yes, thank you, Sheila. And as always, I assume that everyone has read the report. There are a couple of things that I just want to pull out that's worth noting. I think it's worth noting the acuity measures, the acuity and dependency rise through the last month or two due to the pandemic, which, as you'll see through all of my papers, has had an impact on all of us, our patient care and staff. The number of falls, we continue to work this through, and what we have now started to do is to review all of our falls with harm through the new PSURF process, and we will be doing thematic reviews on that. And our falls coordinator is really leading that programme with our teams. The pressure ulcers, which I know came up at the beginning, yes, there has been a significant increase in the pressure ulcers within the acute setting. A number of these have been due to device-related pressure ulcers, and a number of it has been due to our critical care patients who not only have been very, very unwell, but have been prone for long periods of time. And it's really difficult when you're proning patients to try and balance the relief of pressure. So it is, but we will be obviously reviewing all of them and through our thematic review and see what the learning is from that. New complaints, as previously we saw in the first wave, we saw a reduction in the number of complaints. Again, I'll say what I said last time, which is we've had a reduction through the sort of the peak of the pandemic. I will anticipate that we will get an increase in complaints in the coming months as the dust settles and people start to reassess where they are and the care that they've received. So I won't be surprised to see an increase in the number of complaints going forward in the next few months. And as you know, the team have been really focused on the keeping in touch and the clinical helpline, so that has resulted in a slight reduction in the number of their ability to close a number of the complaints, but they have kept in contact with all complainants and made sure they have been updated. And we only have one overdue response for that. I haven't got anything else to add unless anybody wants to ask any questions.
David, I can see your hands up.
Yeah, I just wanted to talk about the use of SPC, which is obviously a very powerful tool for tracking trends. I take the point that it's less useful in times of COVID for the IQPR, but where I think it would be very useful is somewhere like maternity, where we've got a particular focus to be able to really drill down and see the progress that we're making. I'm just wondering whether we can move to introduce that pretty quickly into that area before then cascading back into the IQPR as we get through reset.
Yeah, we can absolutely, David, take that forward and see what we can do with maternity first. Yes.
I think that would be really good because we know that there are aspects of maternity that are making excellent progress, and that way of reviewing progress gives us the opportunity to really focus on the areas we need to focus on, rather than actually having a very broad brush approach. So thank you for that, Louisa.
So thanks for your report. As a board, we've invested or agreed to invest quite significantly in our nursing establishment and their various skill sets. Can we seek assurance around the drive, the ambition, the aspiration to see significant improvement in our quality measures as we move forward? Pressure ulcers, falls, etc.
Yes, you can. Absolutely. That's the premise of us increasing our or improving our skill mixing within our establishment. But as you will all know, it won't be an overnight sudden change. In order for it to be really sustained and embedded improvement, it will take some months and some of the work that we are doing. But yes, absolutely, my aspiration is that we will most certainly see an improvement going forward.
Louisa, does that answer your question? Okay, thank you. Okay, in that case, if there are no other questions for Sue or Helen, can I thank you both for the report, for the clarity of it, and keeping us so up to date. And I do recognise that it's a very strange position that we're in, given that we've just come through the latest wave of COVID, and it does have a big impact on the figures and makes it difficult for us to see the figures in the same perspective as we would normally. With that, can I move to Craig, please, for the finances, which are equally different to normal?
Thank you, Sheila. Yeah, I feel a bit cheated. I know this is the highlight of most board meetings, and I seem to have lost the ability to make it interesting. So we continue to plan to break even this year. As you know, that's been driven by the income figures that are being managed externally to ensure that they match our expenditure figures. So in terms of the things that I'd like to pick out from this month's report, they don't relate to this year. It is about next year. The level of uncertainty around the financial position continues into next year. We're mindful of the need to prepare a budget, although that is really difficult at the moment, because while we can have a reasonably good estimate of our expenditure position, our income position remains volatile. So we have prepared a budget. A lot of the issues in that budget relate to the discussions we've had earlier. So broadly, the draft budget position is the same as it was as we went into this financial year. So it was a deficit budget this year, and we're proposing a deficit budget for next year. It all depends on the level of income. So if income continues in the way it has this year, then that position will get closer to break even than the proposal that you have in front of you. There is some more detail in the closed board, and that detail will come to the open board once we have more certainty. But the principal drivers of the deficit position proposed for next year, excuse me, are the shortfall on the SIP that we are reporting throughout this year, along with some of the initiatives that have been started this year that we would seek to continue. So the Keeping in Touch team, which was mentioned at the beginning of this board meeting, there is a £600,000 cost pressure associated with continuing that into the future. That is included in the draft budget position, as is the increase in the nurse establishment that was just referred to. So there are some costs that have been incurred this year that are driving quality improvements that we would seek to continue. And just picking up Louisa's point to Helen earlier, the importance of, or I think it was to Sue, sorry, the importance of ensuring that we drive value for money from those investments is equally true now as it was previously. So making sure that we do genuinely drive out the quality improvements that the investment is intended to achieve. The other uncertain position around next year is to do with capital. I am expecting us to receive, or the ICS to receive, some indication of what the capital budget will be next year in the next couple of weeks, and so I would propose to report that to the board next month. The question at the start, and Steve partially answered it, around the emergency department. There is a comment in the board report at the end around the emergency department scheme. So we did successfully submit a bid a few years ago now to completely refurbish the emergency department. So the emergency department is woefully inadequate for the number of attendances that we now have. The waiting facilities are not sufficient to deal with the demand that we have, as well as the clinical space being inadequate. So there was a significant scheme to both extend and completely refurbish the existing emergency department. That was a £15 million scheme that would have taken 3 years to complete, largely because we have to do a bit of work, then move the whole department into the newly created facility while we work on the space that's being vacated. And that phased approach to the development creates a significant amount of disruption. And so the decision was made jointly with the emergency department that, given the life that the existing building has, that level of disruption would not be worth the benefits in terms of enhanced clinical capacity. So earlier on this year, we took the decision to cease that scheme. However, in relation to COVID, the Department of Health did announce extra capital earlier on this financial year to improve facilities within all organisations for the management and isolation of patients. And we bid against that money and were successful and have spent around £3 million expanding the capacity of the emergency department. And that's being done in 2 phases. The first phase opened last month and the next phase will open next month. So 2 separate schemes, but dealing with the same fundamental issue, which is a lack of capacity in the emergency department. And I would, when we do get a chance to all go back into the hospital, I would encourage people to go and see the new development. It is genuinely fantastic, and it's an estates team that continues to make me proud. There wasn't anything else I was going to say around the financial position, but I can see there are a number of hands up, so perhaps we could turn to questions.
Thank you. I've got a number of hands. I've got Angus, David, Rosemary and Al. And I'm going to suggest then we take a break, and I apologise, we seem to have feedback for some reason. I don't know if anybody else is getting it. In which case, I'll move to Angus and hopefully he won't get feedback.
Thank you, Sheila, and thank you, Craig. One of the things I've learned is it's helpful just to get a context on how the centre or CCG or whoever, where we source our funding from, is viewing our future funding position and our future financial position. And I wondered, Craig, if you could just add a little bit more colour. We sit here saying we're going to have a deficit of £10.5 million. How is that being perceived, if you like, externally? And it's probably a context with other trusts as well.
Craig, can I ask, can we pick up the questions from the non-execs? Because there may be some overlap. Would that be okay? Can you hold that many thoughts in your head, Craig? I hope you can. So David.
I was going to give some feedback on the CIP, which maybe I could do after the questions, but I did have one question for Craig, and it was around the investments that we're making in what I call the old hospital at the moment, whether it's RAC or anything else. What's our approach on depreciation policy, given that the hospital might have a limited life? Are we accelerating depreciation because that would have an impact on our P&L for the next few years? Or are we sticking to a normal depreciation level and potentially face a write-off at the end?
Okay, thank you, David. And we'll come back to you for CIP at the end, okay? Rosemary?
Thanks, Sheila. And thank you, Craig, for your report. I just had a quick question about cash. So I'm assuming that in the budget for next year, although we're saying there'll be a deficit of 10.5 million, we've got sufficient cash reserves to fund that performance. What I was wondering was, and this may be perhaps due to my lack of understanding, Craig, if we didn't hit the CIP in the next budget year, for argument's sake, and if the theatre work was delayed and therefore we couldn't do so much elective activity because the theatre work didn't complete on time, would we still have sufficient cash to fund that additional deficit? Or perhaps easier, are we quite tight on cash, or is that something I shouldn't be concerned about?
Okay, thank you. And finally, Alan, and then I'll get Craig to draw those issues together.
Thank you. Mine really builds on Angus's question, looking forward. In the white paper, Craig, do you foresee your hands being more tied than they are at the moment? Are the proposals specifically in the white paper that reduce the power of a trust finance director and transfer that power into the broader system? So,
good question. Okay, Craig, can I get you to try and draw those together?
Thanks, Sheila, and thank you, everyone. So I'll try and deal with Angus's and Alan's together. I think in terms of the wider perspective on a deficit proposal, the feeling of uncertainty is all pervasive. So no one is rushing to a judgment over what is a provisional financial position, and they're waiting for the increased certainty on the income position. And indeed, as part of the white paper, there will be system financial targets. So those system financial targets have not been issued yet. And therefore, it's very difficult to make a judgment about an individual organisational position until you understand what the system is going to be aiming for. The position of West Suffolk Foundation Trust is not dissimilar to other organisations. So when I talk to colleagues in those other organisations, they're equally in a position where broadly the proposed financial position is similar to the position that they entered this year with, but recognising that there are some massive assumptions that underpin that financial position. In terms of the relationship with other organisations and the white paper proposals, as I said, the financial targets that will be issued will be system-wide targets, and so the need to work more closely with other organisations is increased. We do have good relationships within our ICS, and relationships that are better than other systems. So I think that will stand us in good stead as we work through the new environment. As was said by Steve in the Chief Exec's report earlier, this is the right thing to do. It is a recognition that health and social care and all areas of health are very closely related, and looking at individual organisations in isolation is not always the most helpful thing to do. So I think the white paper builds on the very things that we have been doing really well within our local system.
I would agree.
The question around depreciation is a really good question, and that has the potential to have a very material impact on our financial position. At the moment, we have agreed with the auditors that we continue to depreciate our assets as we have done it in the past, until we have much more certainty around what the future system programme will look like. So at the point at which we get approval for the full business case, which is some years off, then we can't be certain around the timing of closing the existing hospital and moving into the new hospital. We've agreed with the auditors that at the point at which we do have that certainty around the timescale, at that point we will need to accelerate our depreciation. So at the moment we say the building has got a 40-year life for the purposes of depreciation. Once we know that the building is going to be closing within 2 or 3 years, then we will have to account for that depreciation over a much shorter timescale. It will therefore have a material impact on our income and expenditure position, but that's one that will be well understood by our regulators, and our plans will be adjusted accordingly. The question around cash, obviously our cash position has been artificially boosted because of the measures that were put in place centrally. We expect that to return to a more normal level as we roll through next year. When we plan for a deficit position, that plan, once it's accepted, is matched by borrowing to fund the cash shortfall that's created by the income and expenditure deficit. So if we were to have an agreed plan for a £10.5 million deficit, we would be given approval to borrow 10.5 million to cover that shortfall. If an organisation in year breaches its plan or looks like it's going to breach its plan, and there is a cash shortfall created through that, then we would apply for emergency cash. That's not a great position to be in, and it's not something that it's not a position that we've been in for the 10 years I've been in the organisation. So I don't think we wouldn't anticipate getting there, but the mechanism that others have used where they failed their financial plan is they apply for emergency cash borrowing, and that then comes through from the Department of Health. I think those were the questions, but if I haven't answered them fully, then please do come back.
Steve, did you want to come in with a brief comment before I move to David and that's it?
So all I wanted to just allude to, just to build on Craig's answer around, in a sense, the implications of the white paper for us. People will have noted that there will be a reserve power over Foundation Trust's capital spending limits. I don't think that's likely to materially affect us because we've not had, in a sense, significant reserves, but there are some Foundation Trusts nationally that do have access and a better financial position, which has enabled them to spend at different levels in a way that puts pressure on the national, in a sense, capital spending limits that they have, and so that's an issue that links to the Foundation Trust model. Practically, we will be probably not feel any impact of that.
Thank you for that, Steve. And I'm going to move to David now to comment on the CIP.
Yeah, so in terms of CIP, over the last sort of 3 years or so, CIP has been managed centrally through the Programme Management Office. So I undertook to talk to the lead person in the office just to get some assurance around how we were approaching CIP, given that that programme is effectively being put on hold, for want of a better word, because of COVID. So just to explain that central management involves also a number of managers sitting in that department who effectively work with the various divisions within the hospital where CIP targets have been agreed with, and they also have a central financial support to track and monitor and report against that. That's supplemented by monthly transformation steering group meetings to oversee that process and track it. Those were effectively put on hold as we entered COVID. The opportunity has been taken now to think about this slightly differently. So to put the managers that have been sitting in a central pool to really embed those within the divisions and really take a different approach, in a more transformational approach, working within the division to look for opportunities for CIP in the longer term. That proposal is currently being discussed in detail. I think there was a first meeting this week to look at how that's going to be approached. So I think at this stage, I think all we can say is that there's definitely focus on CIP. The process is going to change. And I think it's probably something we need to return to when those discussions have finalised and we've got a better view on how it's going to be managed going forward. I don't know whether Craig wants to add anything to that, but that was the result of my discussions.
That was perfect, David. Thank you.
Thank you. That's an accolade, David, if you get a perfect from Craig. So thank you for that. That's really helpful. Helen, you wanted to come in. Helen, you're on mute, I'm afraid.
Oh no, epic fail. Yes, it was a perfect summary, but just to give people assurance, that meeting took place. It's been followed by a flurry of emails, and the teams are really actively working this through and working through the relationship between this work, the improvement board, and the new governance structures that we've all talked about before. So there's a lot of activity going on in that space.
Thank you very much indeed, Helen. Right, in that case, as you'll see from the new board arrangements, we have a comfort break. I'm going to suggest, as we're running a few minutes behindhand, that could we shorten that to 5 minutes instead of 10? But please take the opportunity to move. None of us are moving enough on these kind of days. At least we would have wandered out of the north. We are stuck in our chairs. So can I encourage you, please, to get up, to get a cup of coffee or whatever. But if we could keep it to 5 minutes, then we can recoup the time that we're over. Okay, thank you. did take the opportunity to move. I am serious. I don't think we are moving enough. And on days when you have back-to-back meetings and you're working from home, I mean, the level of activity is terrible. And more importantly, as importantly as your bodies, it does have an effect, I think, on our mental attitude and our mental energy. So I do think it's very important. And they are long days and we need all the mental energy we can get. So at that point, we'll tap into Jeremy's mental energy. Jeremy, over to you, please. And the most important part of our organisation, which is our people.
Sheila, thank you for helping us to focus on our well-being, which is crucial and is very much at the centre of our activity at the moment. And I'll get on to that when we focus in on our people plan. Firstly, though, I want to shine a big spotlight on our Putting You First winners for this month. You've got the citations there in your papers. Firstly, for our newly founded portering team at Newmarket, Steve, Don, Graham and Dave have been nominated by their colleagues for the way in which they've established that team and the pretty immediate impact they've had and the benefit that that has brought to colleagues, to patients and visitors at our community hospital in Newmarket. Secondly, then to Gary and Gala. Gary is a central part of how our trust runs day to day in terms of heading up our patient flow team, and is instrumental in so many ways. But the nomination particularly focuses in on something Gary's done really above and beyond his role, and something that is really sort of right at the top of the list really in terms of our concerns around vaccination. We think the vaccine programme nationally is being held as a success, but we know that there isn't necessarily equal take-up of vaccine. It's something that we've been looking at through our own data and from talking to our own staff. And there's an example here where Gary was instrumental with our staff from the Philippines who work for us here at West Suffolk, and in terms of sharing information, providing assurance and encouragement to our colleagues who are from the Philippines. There's a citation there of what Gary did during his annual leave to reach out to those of our colleagues. So for both of those nominations, a very big hand and more importantly, a huge appreciation to them. And of course, they will receive the usual formal thanks and recognition in the ways that we do that, both individually and in our staff communications.
Thank you very much indeed, Jeremy, and I look forward to meeting the portering team when we can get out again. And Gary, I have to say, is one of those people, whenever you see him around, he just oozes positivity and energy. It's great to see him mentioned in dispatches in this way. So thank you for that.
Thank you.
Right.
Thank you to the nominators for those as well.
Absolutely.
In previous board meetings, I have committed to provide a bit more detail around the actions through which our people plan will be delivered. I've previously briefed the board on the flow from the What Matters to You staff engagement that took place in 2020 and how that has been translated into the structure of the people plan. That we've absolutely built it on those sort of 5 pillars that came out of What Matters to You. It has been, as we know, very strange times. One of the huge benefits of the pandemic is that it has really helped us to focus in on what's really important and to make things happen quickly. That's what we've been doing, and certainly the activity in our people plan has been very much focused on sort of the here and now and what's needed now to respond to the pretty unprecedented situation. There are also some other activities that sort of make up our first sort of 6 months or so of people plan work, and I've documented those in the appendix. Gives you some information around who's responsible for those activities and the time frame for delivery of those. It isn't a finished plan in terms of the much more longer term yet. That is intentional. We recognise, as Steve reported in his Chief Executive's report, that our staff survey results will give us fresh insights, not just at organisational level, but also at staff group and departmental level of what we need to prioritise. So we'll be doing that. We expect to receive the final fully benchmarked staff survey results within the next couple of weeks. That's the normal time frame anyway. We don't have a confirmed date yet, but that's what normally happens in the annual cycle of the NHS National Staff Survey. Very happy to obviously to receive questions and suggestions for that. I've provided a bit more information in a form of narrative around one component of the people plan, which is around a restorative just culture and what that means in practice for our HR services, and the advice, the policies, the approach that governs how we make decisions and provide support to staff and teams when within the frame of our HR policy framework. So there's some information in there for you to digest, and then also finally for this month a note of some recent consultant appointments, and you'll see a strengthening there of our position in microbiology with 2 microbiology appointments, and then also a shared appointment with Cambridge in stroke medicine. So that's what I'd want to present. Sheila, I'm happy to take questions and comments. Thank you.
Thank you very much indeed, Jeremy. And I like the tracker because it gives us an opportunity to really focus on the actions. And it's good to have the right words, but it's much more important that we're living it and embedding those ways of working. So with our just culture, it's not about the strap line. It's very much around the way we walk the walk within the organisation. And it's good to see, you know, the fruits of that beginning to be realised in practical measures. So that's really helpful. Thank you, Jeremy. Are there any questions for Jeremy? Rosemary and then Alan.
Thanks, Sheila, and thanks for your report, Jeremy. I really found it very interesting, and it's quite exciting to see what's happening. I just had a question about training, because obviously there's lots of new recruits, there's training around just culture, there's lots of need, lots of different requirements for training over the coming months. And I just wondered if you could reassure us that you've got sufficient resource in terms of both funding and people to make sure the training needs are carried out as they need to be.
Thanks, Rosie. The biggest constraint for training over recent months has been time to do it, and the ability to release staff to do it. And of course, there are different kinds of training that staff both want and need, and the impact of the pandemic has meant that even for training that staff really need, which we normally define through sort of statutory and mandatory type training, even that has presented challenges. We've converted as much of face-to-face to online learning as we can, but that's not possible for everything. We have taken strategic decisions to postpone face-to-face training for a period of time. Our next planned review of that will be in about 2 weeks' time to see, and I'm sure that we will now start to ramp up again the activity and programs that we have in place. So I can give you absolute assurance that
No, I haven't.
We've been working through what we can provide during the pandemic wave of late, and that we're very active in our planning for what's going to happen in the short to medium term.
Okay.
Thank you.
Thank you for that, Jeremy. Alan?
Jeremy, great initiative using Gary. Can you confirm on vaccination whether the results have come through, if you like, on how we've been able to support the more hesitant members of staff to actually be vaccinated? Do you have data on that?
Yes, we do have access to data on that. I haven't seen the very latest position in relation to ethnicity. The last report I received was a couple of weeks ago, where there was a small differential, I think, between white and BAME staff groups. I don't know if Nick has any further update on that, but certainly I will take away an action from this board to include that data in next month's report.
Thank you, Jeremy. Nick, do you have anything to add?
Just that it's been quite, so Jeremy's right, the last data that I've seen as well is 2 weeks old, but that's partly because it's been very difficult to move the position in the last 2 weeks because we haven't had any vaccination going on in the organisation. There are still a few members of staff who couldn't receive the vaccination when we were first vaccinating because they were within a month of having had COVID, and we aim to capture those people with the new AstraZeneca delivery of vaccine that we've now had, and the team are just working out how to do that. So there will be another push at staff vaccination over the coming weeks to try and get us further up from somewhere in sort of high 70% where we are at the moment.
Thank you, Nick. All right, if you could put that in your report next time, that would be really helpful. Thank you. I have no other questions that I can see. So thank you, Jeremy. Thank you. And it feels like we're making good progress around this agenda. So that's really pleasing. Can we then move to quality, safety and improvement? And I can see that we've got Karen in the room. Welcome, Karen. Sue, do you want to open and pass over to Karen?
Yes, that'd be lovely. Thank you, Sheila. So Karen's here to present the maternity paper, and she will cover off the 2 questions that were raised earlier, and also a question that Alan raised yesterday around the why are we reporting red matrix around the number of births, and I'm sure Karen will be able to explain that to you. So I'll hand over to Karen now.
Thank you. Welcome, Karen.
Welcome. Thank you very much indeed. Thank you. So yes, to start off with, so the matrix that we have, we know is not really the way forward of representing or showing our stats. We can't do anything about the number of births. The number of births is the number of births, and we know with COVID, I know that lots of people felt that there would be going to be an increase in the number of babies born, and actually there's very few areas that have actually found that. In fact, it's actually the opposite. But what we are all finding now is that people who've really waited almost a year to have a baby, we are seeing an increase now. But actually, there is nothing that we can do about the number of births. With continuity of care, that will encourage more people to come to us, and we have got plans of looking at different areas. So women who choose to birth here at the West Suffolk, is whether we can provide their antenatal and postnatal care in a continuity of carer programme. That would be fantastic, and then we might encourage more women to come here. But actually, the number of births, there is nothing we can do about that. I know that the questions regarding the training that I would like to address. So the CTG monitoring training. So just to give you a bit of history about this, the package that we use is an online package, and pretty much ever since we've been using it, there was a final date of June every year that everyone had to have completed their training. So that meant that, say like if somebody was to commence their training in July, so say like if they commenced their training in July 2020, that means they had until June 2022 to complete it, which actually almost gives them 2 years. So with everything that's been happening in the last year, we have been going back to basics, and we've been stripping everything back and making sure that we have got everything correct, and obviously reporting our training on a annual basis like this is not robust enough. So we knew that at some point we were going to have to address it and really look at what month by month people are compliant with their training, and that is what we have done now. So that is why you can see that there was a drop, but that's because people thought they had until June this year to complete their training, but actually they completed it in January last year. So we are addressing it, and even I think it was 68%, but even in a couple of weeks we've managed to get that over 70%. So yes, for the next couple of months we will see a little bit, it will take a little while, slower trajectory to get up to our compliance, but we will get there, and it's just because we've actually changed how we report it. So hopefully that explains that one. Yeah, okay, lovely. And then the Labour
I'll
Suite,
check with everybody at the end, Karen, but keep going.
okay. And then the Labour Suite coordinators. Yes, this is something again that you can again see it's a very slow trajectory, and we have been static over the last couple of months of our compliance with the Labour Suite coordinator being supernumerary. One, that is due to COVID. You know, we have been significantly affected by COVID absence, and you know, at the end of the day we do have to make sure that our women do have one-to-one care in labour. But two, we have done a massive recruitment drive, and we are awaiting for 2 now external Labour Suite coordinators to join us, and then we will be able to ensure that there's 2 band 7s on every single shift, which when we've benchmarked it with similar sized trusts, that's the way forward that they do it to actually address this issue. And we've been doing lots of work with our improvement officer to do this.
Okay, thank you, Karen.
Yeah,
keep going.
Oh, so and they were the main areas. I know we from the paper you'll see that we've had the assurance visit, which went very positive. We haven't had the formal report from that yet, but the initial feedback was very, very positive, and that they could see that there was real improvements there. So that was really great. And I've also included the neonatal nursing staff report, which someone did ask me about transitional care and what was the significance really with maternity. And transitional care is so that it enables to keep mums and babies together. And that is a very quick overview of the whole paper.
Thank you, Karen. That was superbly efficient, as the chairman had asked everybody to be. Can I just ask the review that took place? I know you haven't had the written feedback yet, but any highlights or lowlights you just want to touch on before, you know, from the verbal feedback?
I think that the highlights has to be the positivity that came across, and that they could see that masses of work had happened, and that they felt it was a very different place, and that there was great engagement across all areas. So that was really good. The areas of recommendation we are ongoing, really. They could see that we are doing work, but we haven't yet finally completed. So that's things like the triage tool to use, but also increasing the numbers of maternity care assistants, and also the admin staff as well, to provide 24-hour admin support.
Thank you for that, Karen. That's brilliant. I've got a question from David.
Hi, Karen. We've obviously made good progress, and we've got lots of metrics to track and follow. I just wanted to ask, sort of standing back from that, with your sort of experience and knowledge of the department, if you were to pick 3 priority areas that we should really focus on now that are more likely to have a positive impact on outcomes and patient safety, you know, the ones that you really worry about, what are the ones that we should be really looking at and focusing on at this point?
So the ones that, so really continuity of carer. We know if we can get continuity of carer, then actually it's not only better for mums, it's better for babies, and it's better actually for staff as well. But that does require an injection of more midwives, because the numbers of women that they have on their caseload is significantly lower, and we have already been held to task from the regional team about the numbers of cases for our existing continuity of midwives, and they're saying that there are too many already, but we just wanted to get the system rolling. So that would be my number one priority for everybody. I think then the other areas that we need to look at is, now we've got the specialist roles with the consultant, it's really now finer details of our fetal monitoring, because there is new process that is coming, that is under there's training for at the moment, and that it's really about simplifying things, and I think that would really help and address things from a safety perspective. So the fetal monitoring and the continuity for definite, and then it is really about supporting the unit with the right numbers of additional staff for instance, the maternity care assistants, but also some nursery nurses and also the ward clerks. Yeah, they would be my 3 areas.
Okay, that's useful just to give a bit more sort of focus on. Yeah.
Thank you for the question, David. Angus.
Thanks, Sheila. So it's just a clarificatory point in the papers, if I may, Karen. The paper on neonatal staffing, and I know it was in October, but it includes a number of recommendations. And I just wanted to double check, and it may well be in what you presented to us, that all of those recommendations are moving forward and they're on track, if I may.
So you probably are aware that I am no longer the professional lead for the neonatal unit. So this paper, I bought it because of the how it interacts with maternity services, but I do not manage that area. So I can't give you a definite about what is happening with the staffing, but that is definitely something that we do need to look. But it was less than 1 whole-time equivalent. The recommendation was of increasing. So for the neonatal unit, but we do need to look at our transitional care and how we can provide a more robust transitional care. So we really are keeping mums and babies together rather than babies having to go across to transition or to the neonatal unit, and it might not be the qualified nurses, but it would need increasing with the nursery nurses, a band 4.
Angus, does that?
It does. I just wondered whether, I don't know whether it's for the board or whether we delegate it to another, committee. If we could just ensure that all of these recommendations are being picked up, that would be helpful, I think, Sheila.
Okay, thank you for that, Angus. Sue.
Just to reassure Angus, we can build that into our staffing review, so you'll know we've completed a sort of ward establishment review. We'll definitely get Dan to review that in line with the work he's doing around staffing establishments.
Thank you, Sue.
Thank you, that captures it nicely. Thank you for that. Are there any other questions for Karen? Karen, it's really good to have you in the room again. You're still looking cheerful. I know it's been very hard work, but you must feel quite encouraged by having the external view being fed back to you in a very positive way. However well you think you're doing, it's always nice to have it confirmed, isn't it, by others?
Yeah,
so thank you, Karen. And thank you, Sue, too, for bringing that to the board.
Big thank you, Karen. Thank you.
Thanks, Karen.
Indeed. Right, if we could move on then, forward looking again. Craig, Future Systems Board Report.
Thank you, Sheila.
Oh, you are there.
Yeah, sorry, I was struggling to click the right button. So this is just the regular update on the Future System programme. The main point for this month is the SOC, so the strategic outline case has been completed and you've got details in the report. We had a meeting with the national and regional team around our programme. So they're making their way around all of the 40 systems that are working on new hospital developments. The feedback we received was really positive. So a recognition of the work that we've done and the stage that we're at, and a recognition that we are further ahead than I think they had expected us to be. We are pushing against the first wave of trusts that are in the hospital infrastructure plan. So our hope is that our progress will be accelerated, but we're waiting to see the results of the reviews for all 40 systems. The purchase of Hardwick Manor earlier in the year is a notable achievement. The issue of land availability is something that these programs repeatedly come up against, and the fact that we are in a position where we have the land available is a significant positive about our program. Continue to work on the estates work stream, in particular working with our architects who are involved in some of the HIP1 schemes, particularly around what's called modern methods of construction. So this is a method of construction where things can be done quickly and routinely. So you create a building block that is generic, and you build on that, so it makes things cheaper and quicker. So we're working with our architects to explore that. The clinical work stream continues apace, so really good engagement from our clinical staff within the organisation, but also working with colleagues in the wider system, and like to particularly welcome the appointment of 3 GPs to lead the primary care aspects of the work stream, and the way that we can create a much more integrated system that is facilitated through an estate solution. Communication and engagement, again, a lot of work around that. This did come up as a discussion point with the Department of Health. I think there is concern that with all of these programs going on, that we need to make sure that we manage communication in a way that matches expectations with the pace of the funding. So this is a 10-year plan for the development of 40 hospitals, and I think they're just alive to the risk that there'll be 40 systems all creating an expectation that they'll have a new hospital tomorrow. So just working carefully with the Department of Health and the regional office around communication to make sure that our communication sets the right level of expectations, particularly around timescales. The financial aspects of the new scheme are obviously a concern for the Department of Health. So, as I said before, they're trying to manage the timing of the cash flows around the hospital programme. So there's a strong focus on our financial model. And then finally, we continue to build on the really excellent work we've done around the digital programme within our existing organisation, and making sure that as we move into the new system, it is one of the, if not the most advanced digital system in the country. So happy to answer any questions.
Thank you very much, Craig. Do I have any questions for Craig? Alan?
Hi, Craig. We had quite a few questions last night from our governors about the general process, and hopefully we'll be addressing those. But in general, as the program proceeds over the next few months and years, will we be giving sort of bulletins to the public, given the constraints you just said, about things like the travel arrangements or things that different groups of people care about, perhaps alongside the engagement process? How will we do that?
So the communications is a significant work stream within the programme. You mentioned the engagement group that will have representatives of both the clinical and the wider community, including governors. All of those issues will feature. Obviously, some are outside of our direct control, but the good working relationships we have within the wider local economy will mean that we'll be able to address some of those issues. Transport is a particular issue, particularly as we try to ensure that the new system is environmentally sustainable. So that goes beyond just the way in which we build any structure, but does incorporate travel arrangements, parking, and so on. So it is a really important aspect of the new developments, and we will be working with colleagues, but also to ensure that we effectively communicate on those issues. So part of the role of the engagement group will be to collect those questions and those areas of concern so that we can make sure that we address those in any communication we issue. So inclusion in regular bulletins will be absolutely something that we'll focus on.
Thank you, Craig. Helen.
Just a very quick one, really. So talk of modern methods of construction and standardisation has shades of rack planks, Craig. So I'm sure we're on the case, but I think people might appreciate some assurance around that.
You mean you're afraid we might build another generation of Best Buy hospitals?
Well, I'm sure the people who built the current generation talked about modern methods of construction, standardisation, etc., etc. And it just sort of raises some alarm bells with me.
Yeah. It's a good point to raise, Craig.
Yeah. So it's something that we're probably more alive to as a risk than most other organisations. That has been the focus of some of the discussion. I think one of the things that goes in our favour, and again, this is about always seeing the positive, is that the land that we have acquired has some particular challenges, not least in terms of the outlook, but also working with the environment and in particular the veteran trees that are on the new site. So that does mean that the solution that we will create in a way will need to be bespoke to address those challenges, and therefore the applicability of modern methods of construction might be more limited than it would be on a completely greenfield site. So so yes, it's obviously an issue that we're alive to, but you're right to make the point, Helen, and perhaps I should have called it out.
Thank you. Steve.
So as our thinking develops, that might be something that we might want to take some independent advice on as we progress our plans. I'm just conscious that there is both shall I say, modern methods of construction cladding issues, and we might want to try and understand and foresee some of the the future consequences of any design choices that we take. And the other point I just want to make is I think I'm really keen that we engage both our public, our members, our governors, our board in the design and the co-production of our thinking, and I think we're committed to that, and it's just worth underscoring that. That's one of the things, as I chair the programme board, that we're very, very live to, and Craig's alluded to what we are doing around that, but we really want to involve as many people in terms of public as well as staff, as well as our community going forward.
Thank you, Steve, and that's an important point. Okay, thank you very much indeed then, Craig. We shall know, I mean, you asked the question, Alan, about regular updates. and there will be regular updates to the board, to the governors, to all concerned. It's going to be very important that we keep a sense of realism, but also a sense of progress. So thank you for that. Now, I'm not going to move forward because I realised once I'd started on Craig, I'd missed a chunk of your report, Sue. So my apologies to you, Sue. And can we go back to 14.2 infection prevention, etc., please?
Absolutely no problem, Sheila. Thank you very much.
To brevity, but that's a little bit too brief.
Well, I was so quick you didn't seem to hear me. So the IPC report, you'll see this is an ever-evolving report that we're starting to build a dashboard into. I'll take it as read. I think the couple of things that I just really wanted to raise with you all was to note the reduction in our number of COVID outbreaks and our reduction in our nosocomial probable and definite infections. We have had a slight increase in the incidents relating to COVID-19 management, which you would expect during the high number of patients we had in the organisation at that time. I am pleased to say that our swabbing within 24 hours of decision to admit is on the up again, up at 97%, and we continue to do a root cause analysis just to make sure everyone is swabbed in a timely fashion. I was going to bring your attention to the fact that we've also had some further updates from NHS EI, and we will be incorporating those into our dashboards going forward. I'm happy to take any questions.
Thank you very much indeed, sir. David.
Yeah, so a lot of the metrics and monitoring is around the acute side of the trust. I'm just wondering if you could give us some assurance around what protocols are in place for infection prevention and control within the community teams.
So within the community, so obviously Rosemary and Glastonbury are our community beds. So they follow the same processes that we do within the acute setting. And certainly the infection prevention control teams, especially Amanda, who is sort of designated to community care teams, works with them to make sure that we're observing all of the relevant IPC guidance and PPE, etc. within the community. It is quite tricky, obviously, when you're going into patients' homes because they are their homes. But I've certainly been out with the district nurses, and they do follow all of the requirements that we set out for them in the policy and guidance.
Okay, so we have policies and tracking in place to monitor that.
Yeah, and we do. While it's very difficult to audit patients' homes with regards to that, but we could certainly look into how we do a PPE audit. It's just that they are quite often lone workers, and they're, obviously, you can imagine, they're quite widely spread.
I know, David, you will love going out with them when you can. Rosemary.
Oh,
then Steve.
Oh, thanks, Sheila. Thanks, Sue. A short presentation, but there's lots involved in this whole area. I just wondered how confident you are that you've got sufficient resource to help you do what needs to be done in this area.
So you will know, and the situation is still the same, that we were unsuccessful after 4 attempts to recruit to a lead IPC nurse or a lead IPC practitioner, and we have acted somebody into that position. It certainly hasn't, we are certainly feeling the gap there. We have backfilled with a band 6, but we do still have a lead IPC nurse vacant, and we are looking to when the most appropriate time would be to go out to advert for that post, because as you can imagine, they're all a little bit busy at the moment and not necessarily looking for new jobs. But the other thing that I'm doing is working across the system with the CCG and looking at what we can do sort of to pool some resources with Lisa and her team. So I'm hoping that we will get that sorted in the near future. Okay. But that said, we've had immense support from Ian Coe from eCare, who's helped us bring some of the data collection into the 21st century, as it were, and also immense support from our safety investigators and learning teams, Lucy's teams, because as you can imagine, it has been a huge piece of work, and we are still working through the backlog. But we have got every bit of data is there. We will be able to report it all fully, and we are currently doing all of the SI review meetings for the outbreaks.
Yeah, thanks very much, Sue. I'm just very mindful of the fact you've got a huge workload there, so I just wanted to check.
It has been fairly all-consuming. Yeah. We also had a visit from our regional infection prevention control nurse, and he did a walk around a couple of our ward areas, AAU and G5, and was very complimentary of the cleaning that we have in this organisation, and I think that's tantamount to the fantastic housekeeping team that we have, and also gave us some pointers on how we could improve in some of our areas to make sure that we absolutely are at the top of our game.
Okay, thanks.
That's really good. It's that external pair of eyes again, which I think, you know, gives us a considerable assurance. Thank you, Sue. In which case, could we move on to the staffing report, please? Oh, sorry, Steve, you wanted to come in at this point.
Thank you, Sheila. It's an in-house cleaning team, which is fantastic, but that also gives us lots of control and responsiveness, and fantastic. Also, there's great lessons that are outlined in the paper that Sue's alluded to, and I think we're going to take staff through some of those lessons at the next staff briefing. But the point that I raised earlier, there is something about how we get some of that learning into our broader communications and narratives with teams and so forth. So I think we really need to pick that up. And I think that was also discussed at the Nursing and Midwifery Council yesterday, wasn't it, Sue? Some of those lessons.
Yes.
Final thing, David, just in terms of just to echo what Sue was saying around, in a sense, PPE, when I went out and shadowed the community teams just before Christmas, and you will have seen me in my doffing and donning on the doorsteps, because I set out some of the pictures and the processes that the teams were following, but that was a very much a focus of the conversation of the teams, making sure they've got enough kit and making sure that they're following it. So they're very, very live to that, but it's not straightforward when you're doffing and donning outside people's houses. That's the only thing I would say. It's you go from a warm car to a cold shall we say street into a warm house, and if you wear glasses and all the rest of it, it's not straightforward, but the teams do an amazing job.
Yes, and every house is different, shall we say. Okay, thank you, David.
Yeah, I thought I'd just probably say at this point also, I joined an incident management team meeting, I think it was about 2 weeks ago, which was a sort of multi-agency response to particularly the nosocomial infections in the hospital. So that was very assuring to see that the trust are working right across the system in their approach to infection prevention and control. So I thought it was worth saying.
Thank you, David. Yes, most certainly worth saying. So sorry, I interrupted.
Just to go back on Steve's view about the NMCC, so we did have our NMCC meeting yesterday, which is our Nursing Midwifery Clinical Council. There were 50 plus nurses, lead nurses in the room. We did talk about the immediate learning from the outbreaks, and a number of the ward managers who had experienced outbreaks did explain what they thought we'd learnt too, so that is there. And next month there's going to be a full presentation from a group of the ward managers to explain how it felt being part of an outbreak, because I think we must remember it isn't just about the fact that it's an outbreak. It does make all of the ward managers absolutely felt personally responsible. They felt distressed, they felt anxious. So I really think it's an important thing for us all to share and learn from, because there is no blame in this situation, and we are really clear with that, but it doesn't stop ward managers feeling very responsible. So I think it will be helpful for them to share that at the next meeting, and then we can really explore that.
I think that's a really good thing, because we've always talked in the NHS a lot about no blame cultures, but the NHS has been inclined to blame in the past, and it's really important because we learn from those incidents so much. Okay, thank you. In which case, could you move to the nurse staffing report, please?
Yes, of course I can. So Dan's given his apologies this month, but as you will see, it's his usual full comprehensive report. Just to note, which I'm sure you will all not be surprised at, that we had a significant challenge in our fill rates across January. This was due to a mixture of things. This was increased acuity and dependency in the organisation, but also an increased level of sickness or self-isolation from our staff members. We did do what we could to mitigate, and you'll see the additional section that is COVID response, where we talk about how we utilised other members of staff in the most creative and flexible way. And I want to take this opportunity to thank all of those staff who really, really did help us at a time of real stress especially our AHP colleagues who literally overnight produced a plan of how they were going to support. We had moving and handling teams coming in and helping to support critical care with the proning of patients. We had all sorts of people coming forward. So huge thank you. However, it doesn't, while that mitigated it to some point, it doesn't mitigate everything. So as you will see, we have seen an increase in our incidence and a reduction in our nursing quality indicators. But as already explained, we are seeing an improving picture in February. I walked around the wards last Friday and certainly it is feeling a lot better. We have reduced our number of staff off sick. We have got people back in the organisation and they are starting to re-establish, especially as now we've closed or we've put a lot of the wards back into normal activity. That's making them feel a lot more positive about the future as well. I'm happy to take questions. I wasn't going to raise anything else other than that.
Thank you. Thank you, Sue. I haven't got any hands up. Yes, I have. I've got Steve. Anybody else?
Sorry, Sheila. I just wanted to. I was on a regional chief exec call, and our plans to reduce our nursing assistant vacancies to 0% by April were called out as one of 3 trusts across the patch that was doing really great on that. So I just wanted to say a big thank you to the teams on that, but also ask the question, how close to 0 are we going to get? Because I think it would be great if we could get to 0.
And great for patients.
Our establishment review will be helping us on that respect, because as you know, we are going to be increasing our number of registered nurses and slightly reducing our number of care support workers. So that will improve from a care support worker basis, but it will mean that our RN vacancies will go up because obviously they will be in the system and they are going to take some time to recruit to. So while we've got it in our aspiration, it will take a while to get that. And I've noted that we will bring back a sort of implementation plan of how we plan to do that next month in the staffing paper. But it's always our aim to get to 0%. And what I think is really important for our organisation here is that our care support workers tend to stay. We don't have a high turnover. They come, they like it, they get well supported, they have fantastic support from our education team and the rest of the organisation. So I think that's a real accolade for us.
Thank you. Yes, that retention is really important because it tells us how we're doing in many ways. So thank you for that, Sue. There are no more questions on that one. So could we move on to the improvement board? And I think we can probably take pretty much that as read, but I'm sure there's some highlights you just want to touch on.
Just to say, as I say, take it as read, just to point out that you'll see there was a new look improvement plan for maternity where we were aligning all of the sources of assurance required into that, and what we are now working on is revising the entire improvement plan that was originally written in response to CQC must-dos and should-dos. We're now building it more into a trust improvement plan, and next month you will see a new look approach to, for example, patient safety, where we will be aligning all of our HSIB, our external reviews, our coroner's reports, and all of the learning and recommendations for those will be built into the improvement board into the improvement plan, so that we can then start to develop a really robust assurance plan on how we measure the quality and impact of those improvements.
And I'm really pleased to see that progress, because although in many ways the trigger was the CQC must-dos, actually it was always the intention to bring the broadest range of things together into one plan. I've seen too often where there are multiple plans and things drop between, and very clearly that's the improvement board is achieving, preventing that happening. That's a very clumsy sentence, my apologies. Okay, are there any questions for Sue on that? If not, we'll move on to the quality and learning report. Sue, it's you again.
I'll take that as read. Just to point out that we are now moving forward with our PSERF Go Live. We are now, I think, in week 3 or 4 of our new look SI emergency. I can't remember, it's EIR. emerging incident response meeting. It's basically where we have a centralised weekly meeting with myself and Nick, the quality and safety team, and the clinicians, where they bring cases and we have a round the table discussion. And this is how we're going to move forward. Those incidents then get reviewed, and they either go down an agreed pathway for thematic review as part of our PSERF agenda, or they get a separate individual root cause analysis. And I think it's fair to say that each meeting we've had, we've progressed it even more. And this week's meeting, I think, was really robust, and we saw some clinicians come. It's a supportive meeting, and it was really interactive. And I don't know whether Nick or Richard want to add anything to that, but I'm happy to take questions.
And I've got Richard waiting to ask a question, but Richard Jones or Nick, is there anything you want to comment before I open it up? No, in which case, the other Richard, please.
Not me, thank you, Sheila.
Thank you. That might be a useful forum to bring non-exec directors in to provide a level of assurance and oversight of that.
That's an excellent idea, because I think for the new system, you know, it is very different. So I think that's a very good idea, and I'm sure non-executives will be only too keen to get that assurance. Richard, my apologies. Too many Richards in the room.
That might feed into my question, which is I'm still trying to get my head around the PSERF process. It's a great report, Sue, thank you. So my understanding, and correct me if I'm wrong, with the PSERF is that to some extent the trust can choose which cases it investigates in great detail, and the implication being that you downgrade some of the investigation to cases that were previously mandated. How can we reassure our patients and their relatives that the trust is never going to be in a position to cherry pick those cases that are less challenging to investigate?
So the remit of PSERF, and you will know that we brought the thematic review options to the board, or we brought it to you all a couple of months ago. It's where we agree as a board what our thematic investigations will be, and those will be the ones that will go through a thematic review, if you like. Other serious incidents or other incidents will be agreed at that panel, but we won't be cherry picking. There's a guideline of what we should be doing and how we should do it. So it doesn't exclude doing a deep dive into individual incidents. So for example, so we had a falls with harm that would go down the falls improvement plan and thematic review. We had a separate one which was an ED issue, and that will go down a root cause analysis. I don't know if Nick wants to add to that.
I'm going to bring Nick in at this point, and then I'll bring Angus in with a question. Nick.
Thank you, Sheila. So Richard, I think my answer to that would be because the board sets the board as a whole sets that group the things that must be investigated, as Sue said. I think the advantage is, you and I know, because it was a topic at the Learning from Deaths group just last week, or maybe even this week, that we had 2 incidents on the same ward several months apart that really were almost identical, and but both resulting in death, and it felt like we hadn't learned what we needed to learn from the first incident. And so what we did this week at the meeting was direct PSERF in the direction of those two incidents. So we can at any stage, whenever things come to our attention and however they come to our attention, and I think the advantage of the panel position of me and Sue and Richard being there is that we can triangulate things and send PSERF off to do the work whenever we need it done.
Thank you, Nick. And I think Richard Jones's suggestion about a non-executive dipping into that group, Richard, I would suggest it's probably appropriate if one of the people who does is you. Angus, if I could come to you.
Thank you, Sheila, and many thanks for the report. Naturally, I alighted on page 190 with the raising concerns data. Just a reflection looking at this data. I think, Jeremy, you said you were going to bring a paper next time round on freedom to speak up, etc. The question that was in my head was, I can see that this and it's reassuring that we're seeing concerns being raised. It's somehow getting assurance that we're actually hearing them and responding to them. And I just leave that as an ask really for you to reflect on. I think when we look at that in deeper detail next time around, it would be helpful to get that assurance.
Yeah. Jeremy, can we be assured that that is an issue we will address, particularly through, because I think, you know, it's an accusation that's been made about that we listen, we don't hear.
Thanks, Sheila. Yeah, one of the things that you may have spotted in my report was, in addition to the board action around activity, actually completion of the board self-assessment around freedom to speak up culture and our own leadership on that. And that was something that the board last did, I think, just before I arrived in the trust, so around about 18 months ago. But it is something that, as a result of our recent limited assurance internal audit that took place last year, and the action plan that flowed from that, we committed to an earlier than normal reassessment of our board self-assessment. Clearly, that's something that I will facilitate. I can't reflect on behalf of all of us there, so there will be a need for you to input into that. But that process will be happening over the course of the next month.
Okay, thank you for that, Jeremy. I've got Alan and Rosemary.
I particularly like the last section in the report, Sue, which is the action and learning from public feedback. Can you just clarify, do the members of the community who've given that feedback, are they shown the actions and learning that we show here? Does that go back directly in our letters and so on to the people who've given that feedback? I think it's great that it's in public board because it's very honest and it's emphasising the action and learning side. But do we give that directly to the inputters?
So if they formally write in a letter of complaint, Alan, yes, and that goes back to it, but we can always do more. So we are looking to how we can improve that feedback to the community that provide, even if it's an informal feedback. I'd like to say yes, we do if they write informally, but I'm not 100% sure we're brilliant at it. I think it's always something we could improve.
Yeah, but so often they say, don't they? Don't worry about what happened to us. I just don't want it to happen again. You know.
Yes,
that's what they want, isn't it? You know?
Yeah.
Thanks.
Absolutely.
Thank you very much. And Rosemary.
Thanks. Just very quickly, so I was actually going to make a similar point to Angus on raising concerns on whether we would be looking at lessons learned from those concerns that were raised, rather than just looking at each concern individually, looking as a whole about how we could learn lessons and roll that learning through the organisation. But I guess that's covered with Jeremy's answer.
I think it probably is. Sue, did you want to add anything?
No, I that's fine. I mean, the freedom to speak up guardians from a nursing and midwifery perspective, I know that Dan has regular meetings with them to try and pick up any thematic things coming through in real time, Rosemary, so that we can address it sooner rather than later. But it's not a formal, obviously, it's just to pick up if there are any themes coming through, but he does have a regular meeting with them.
Yeah, because I went to your Nursing and Midwifery Council meeting, and you do that lessons learned there, don't you, where it's not a blame thing, where you actually discuss the learnings and so on, which I thought was really, really interesting. Thank you.
Yeah.
Thank you, Rosemary. And thank you, Sue, for the report. So thank you all very much, in which case I've actually, the chairman is back on track now, and we can move to item 16, which is the governance report. Richard, over to you.
Thank you very much. So as always, I'll take the report as read. There's a couple of things I was just going to flag in terms of bringing to people's attention. In the future programme for the board, there is an inclusion of a annual governance review. What we'll do is pick that up with the regulator, NHSEI, as part of our discussions because as a foundation trust, there's a requirement to undertake a scheduled, well-led review. So we will have a discussion with them about what that could look like, and that will also provide an opportunity to pick up some of the more recent changes to the CQC assessment framework, and think about how we could use that as part of our approach. So just to flag that, I suppose, as an issue for the board, which we'll come back to on with more detail. And the other thing to raise is that the report does include NED responsibilities, but clearly they're subject to review, both in terms of some of the changes in terms of roles, and also the introduction of the new structure for the committees, which we're certainly looking to implement from April. But I'll take any questions on the report in terms of issues within there.
Thank you very much indeed, Richard. And can I just comment on the NED responsibilities? They are in a state of flux. Clearly, we've in the last year, we've had 2 new non-executive directors appointed who at the moment are working more in temporary roles than anything else until we move to the new committee structures. That's really exciting. We need to get that implemented. We fully recognise why we haven't done so. We did have a few distractions from COVID, unfortunately. But the sooner we get moving into that, the better. So there's some changes to come, and also, of course, sadly, we will be losing you, Angus, at some point. We'll make that last as long as possible, I can assure you. But as you all know, we have a strong field of contenders for the audit chair role moving into the future, and clearly adding to the team will bring a new set of skills and experience. Not just in relation to audit, but in relation to other skills and other useful things in their background. So that I would just recommend you the list as it is and say it will change. Any questions, comments? I'll take that as no. Thank you very much indeed. In which case, can we move to any other business? Nobody's flagged any to me. Is there anybody sitting on something that is urgent? I will take that as no. In which case, can I note the date of the next meeting, please, which will be the 26th of March? And can I thank you all for your succinctness, because we have finished ahead of schedule. Now, admittedly, we have put extra time in there after the last board meeting, but I do welcome the fact that we can be businesslike and succinct and get through the business, and that you have the opportunity to take a proper break. I suspect many of you will stay at your desk and catch up on your emails and your phone calls. But please do, in the interest of your well-being, get up and take some exercise in between, and I will see you all back in the room this afternoon. So thank you all very much, and thank you to our members of the public who have attended out there. We can't see you, unfortunately, but we do welcome you, and we do value your questions that you send in now in advance. So thank you all, and I will see you this afternoon.